Hello, everybody. Welcome to Global Response to COVID-19. This is webinar number 16. This meeting is sponsored by the Panamerican Trauma Society, the American Association for Surgery of Trauma, International Relations Committee, the World Coalition for Trauma Care, the University of Miami, and the Virginia Commonwealth University, VCU. We have been doing this meeting for 16 weeks, and we keep doing this because we still have a lot of problems happening with the surge in South America. And now we're having a resurge in increasing cases in North America. And today we're gonna focus on talking about reopening and what's happening. Is a second wave or just increase of the first wave. We're gonna have presenters and panelists from North America and from Europe. Remember, if you are in this meeting, you're allowed to be recorded, and this meeting is going to be have a link at the Panamerican Trauma Society website. Now I'd like to invite Dr. Michael Butanos to introduce the panelists and the presenters, please.
Thanks, Dr. Martos. It's really a privilege to have co-hosted this with you for the past 16 weeks. It's really been incredible. So we have, again, great list of panelists. We start with Dr. Ricardo Lima, Professor of Surgery at Federal University of State of Rio de Janeiro and head of ICU at Samaritano Hospital in Rio, Brazil. We have also Dr. Christoph Josten, Professor of Surgery and Dean of School of Medicine at University of Leipzig, Managing Director of the Clinic and Polyclinic for Orthopedics, Traumatology and Plastic Surgery at the Leipzig University Hospital. He is the former president of STs, former president of German Society of Trauma, and former president of the German Spine Society in Germany. We also have Dr. João Grangeiro, CMO Olympic and Paralympic Games in Rio in 2016, and also General Director of INTO-MS in Rio de Janeiro in Brazil. We also have Dr. Carlos Yanes, General and Acute Care and Trauma Surgeon at Salud in Zaragoza in Spain. We have Dr. Luis van Batten, Professor of Surgery at the Federal University of Paraná and the Pontificia Catholic University of Paraná, and President of the Brazilian College of Surgeons in Brazil. We have Dr. Thomas Scalea, Panamerican Trauma Society Executive Director, Professor of Surgery, University of Maryland, and School of Medicine, and Physician-in-Chief of the Adams Cowley Shock Trauma Center in Baltimore, United States. And hopefully, although I don't see him online, we have Dr. Felipe Vega, the President of the Pan-American Trauma Society and Trauma Surgeon, Department of Surgery at Hôpital Ángeles Lomas in Mexico City in Mexico. So we welcome all the panelists. Back to you, Antonio, to introduce the presenters.
Yeah, today, thank you, Michael. We're going to have two presenters. One, Dr. Raul Coimbra, the Executive Director of the World Coalition for Trauma Care, Surgeon-in-Chief at the Riverside University Health Medical System, Professor of Surgery at Loma University School of Medicine in California, Dr. Omaida Velazquez, the Professor Surgeon Chair of the DeWitt Family Department of Surgery at the University of Miami Miller School of Medicine, and Dr. Fabiano Perdigao, a Hepato Biliary surgeon and Hepatic Transplant surgeon at the Hôpital, the Universitaires Pitié, Salpêtrière, Universitaires Sorbonne in Paris, France. Dr. Perdigao called me 1 hour ago. He needs to go to surgery. I had his presentation. He went through his presentation. I'm going to show his slides because it's good for discussion. Dr. Raul Coimbra, I'd like you to please welcome all the international sites that have been joining us for the last 4 months.
Thank you, Antonio. Yeah, I would like to welcome all the participants in this webinar today, members of all the societies that are on the slide in front of you. As I say every week, this is a tremendous effort that Antonio coordinated with Dr. Abutanos, Pan-American, the World Coalition, and the AAST International Relations Committee to embrace all these groups all over the world to contribute to knowledge as we face this pandemic. So welcome all, and I hope you guys enjoy the webinar today.
Thank you, Dr. Coimbra. So we went through this webinar to multiple phases. We had like Italy was, Europe was having like a surge and a peak. and North America was not, so had time to prepare. Then you have our peak here in March. We closed, and then we reopened, and then South America got the heat. Still have a big heat, but now Dr. Coimbra, Dr. Velazquez are going to talk a little bit about what's happening in North America. So, Dr. Coimbra, please tell us what's happening after reopening in California and the United States. Sir, thank you very much for joining us again.
Thank you, Antonio. So I was, since last week when Antonio asked me to speak one more time, I was reflecting on what the message would be. Because I really thought about a month and a half ago, when I presented to you our strategy to reopen the hospital after we basically canceled most of our elective surgery, that we had the right strategy. I really thought we had it. And 4 weeks later or 5 weeks later, the situation is very different. So if you remember, I discussed with you how we would go back to normal. And I think this is still valid because many places in the world are coming off of this, the initial wave, the first surge, and have to prepare to reopen hospitals as society reopens at large. And to go back to your regular surgical practice, you need to understand what COVID-19 prevalence is in your community as well as in your hospital. You need to look at your hospital bed availability, your hospital resources, your ability to test in your hospital for COVID-19. You need to look at the backlog of your elective surgery that you stopped doing for some time to start prioritizing patients and develop a strategy how you're going to deal with outpatient surgery versus inpatient surgery as hospital beds are still being utilized for COVID. So there are many ways to look at prevalence and assessment of COVID in the community and the hospital. We used a strategy that we felt was pretty good because we had really bent the initial curve. So we look at sustained reduction in the rate of new cases in the community for 2 weeks, hospital admissions for 2 weeks, and ICU admissions for 2 weeks. And once we saw those numbers stabilizing or decreasing, we felt pretty good that it was time for us to go back to work and reopen elective surgery. Bed availability as well, which hospital has a different strategy. So you got to determine for your hospital, based on the community that you serve, the characteristics of your hospital, what's the percentage of hospital beds that you can make available for non-COVID patients, the percentage of beds that you make available in the ICU for non-COVID, and ventilators. These are the three most important components to reopen a robust surgical practice and start doing big operations. Obviously, you need to have the PPE, you have to have normalization of the supply chain so you don't run out of the masks and the N95s and ventilators, etc., and some medications that during the initial phase were in shortage. You got to test. We are part of the group that supports testing everyone preoperatively. I know this is very debatable. There's tremendous discussion. We had a discussion last week about this with Tina Gardner from Norway and Hepato and others, because testing is not as widespread as we expected. So every place is different. So I understand it. We are part of the testing, the group that promotes testing for everyone. Then you need to look at your backlog. Obviously, you need to prioritize cancer first, cases that are related to time-sensitive diseases. Look at those that will require an admission to the hospital. and make sure that we don't inflict more harm if we delay cases. And then I described this to you. We decided to take a very careful approach in our stage 1. We decided to open only 50% of our OR capacity. We decided to keep open blocks, so we remove all block time and said, you're gonna have 50% capacity. Every block is open. Nobody owns a block anymore. And you can put in your cases when you want, as long as we have only half of the rooms running. And that worked really well. Obviously, trauma and acute care surgery were not into this mix because those cases never stopped. And then we decided that once we opened 50%, we would do a 2-week reassessment of the situation in the community, in the hospital, in the operating room, and would see if it was appropriate to go to phase 2. Patient safety was always very important. The communication to the community, to our customers was important. And I described to you that I had very serious doubts if doing all that and try to reassure the public that the hospital is a safe environment for patients to come and receive their surgical care, whether or not they would come. And our experience has been that about 25 to 30% of our patients have declined surgery at this point and decided to wait longer. And I think this will have a significant impact in healthcare outcomes in the near future. Anyway, we moved to stage 2, again, carefully. It was 75% of our capacity. We continue with our open blocks, and this time we decided to run it for 4 weeks to be even more careful and then reassess. And since we saw the numbers not increasing significantly, we decided to go to stage 3. And as soon as we hit stage 3, which brought our full OR capacity back, and the surgeons start scheduling cases that were waiting for a long time, we are back where we were, almost to square one. And it all came back in just 4 or 5 weeks of this plan. So I will share with you what's happening where I am in Riverside County in California. This is the total number of cases as 2 days ago. We're having 500 to 600 cases, new cases every single day. Interestingly enough, the number of deaths has not caught up with the number of new cases in hospital admissions. But the county has a pretty good data system that monitors this every single day. And I want to point out to you that if you are in the same situation that we are here, this number is very important. The doubling time is very important to monitor on a daily basis, because the longer the doubling time, the better is the situation in your community. Our doubling time when we decide to open or reopen our operating rooms was about 35. And now our doubling time is decreasing and we are at 26.7. These are deaths. I'm not going to spend a lot of time, but you see the age distribution. Females and males are about the same. This is the important data. The initial trajectory is the blue line. So had we not done anything, including the lockdown of society and a campaign to encourage use of masks and hand hygiene and people working from home, etc., the trajectory would be a lot steeper. But as you can see, the number of cases continue to increase and our doubling time is decreasing. So this is the last day here is from June 28th, and the projection is for July 7th. So we are going to go from 16,000 cases to 18,000 cases in about a week, which new cases, which is a problem. And this is the doubling timeline. So the yellow line shows how well we were doing. And our doubling time was between 30 and 35, as I mentioned, and it stayed there for some time. And all of a sudden, and here is all the events that happened, but we revert the state orders to reopen on May 1st. We went to a second phase on May 8th. And on May 22nd, we went to a phase 2.5 of reopening. As you can see, 2 weeks later, more or less, after these measures of reopening took place, the curve starts to change. And by between June 5th and June 8th, our doubling time starts to decrease and get worse and worse. And obviously we had holidays, we had protests, we had a number of events that a massive number of people got together. And this is, as you can see, the number of new county daily cases on a daily basis. And you can see that the 7-day average, which is the right measure, keeps going up and hasn't stabilized again. So obviously, suffice to say that things are getting worse. And this is deaths, as I told you. Interestingly enough, the number of cases and hospitalization is still going up. The number of deaths is not, has not caught up with the number of admissions, but we believe that the profile of the disease is changing a little bit, number one. And number two, we are going to see an increase in mortality as the weeks go by, particularly after the holiday on July 4th, our Independence Day. And again, this is a summary for you of, we are at about 20,000 positive cases. We have tested 222,000, and this is another important number here, the positivity rate. The governor of the state of California established that if your positivity rate were above 8% for a 2-week period, you would be put on a 2-week watch list as a county. And if you do not decrease the positivity rate in 2 subsequent weeks, the state would intervene and take measures in our community to attempt to bend the curve. What he was saying was, if you don't behave as a county, and if you don't do what you have to do from a public health point of view, we are going to come in and tell you to lock down again. And that's very scary. It turns out that we were below 8, as you can see by the yellow line, and then we went up, and now we are between 10 and 15. So today, the governor will have a briefing at 12 noon. 3 days ago, he put 7 counties on notice and changed things in another 7 counties, including Los Angeles, closed all the beaches in Los Angeles, closed all the bars, and a number of other measures. And obviously the fear is that he will declare a societal lockdown again in the state as we approach the holiday this weekend. One thing that's very important is to count on good data. This is our hospital dashboard on a daily basis. So I have at the tip of my fingers a snapshot of everything that's happening in the hospital. And you can look at this for yourself. But what I want to point out to you is that we developed now a strategy that says continue, slow, stop, or revert the opening of the hospital. So this is about number of beds, this is about ICU occupancy, and then we measure the ICU admissions on a daily basis, and we measure the number of hospitalizations. Anyway, this is a very comprehensive dashboard that allows us to make more educated decisions about the surveillance that's necessary inside the hospital and the profile of the epidemiology of the disease inside our hospital and inside our county. And we measure, obviously, our ability to test. we have admitted in the last 3 months 1,500 patients for this disease. We still have a number of patients in the hospital. Today we have about 70. We had to reopen a second ICU, which all indicates that we are doing worse than we thought. And here is the positivity threshold that I mentioned to you. We are above the 8%, which puts us as a county at risk for a new lockdown. So this is the situation. And the question is now what to do. So as I mentioned, I don't have the answers, but we are monitoring these numbers very, very closely. And I think that the concept that I discussed with you of having a hospital within a hospital is very important. We have to learn how to coexist with this disease without denying care to patients that do not have this infection. And it's always a matter of resource utilization. Now, if the second wave, which to me is still part of the first wave, I don't think this is the second wave, this is a continuation of the first, it's just the second peak, because we behaved poorly as a society. If that second wave is massive and we go back to where we were, that everything has to be canceled, obviously, we won't be able to provide care to those in need. So we are exploring all possibilities, even creating a large tent hospital on our campus to put all the COVID patients that do not require ICU, so they don't use precious hospital beds that can be used for surgical patients that need surgical care. So I'm going to stop here. I know that there is a lot of discussion, and I hope we have a vibrant discussion. I don't have all the answers, but the message, I think, is that we need to try to think outside of the box and develop strategies within our hospitals to be able to deal with the second surge in a way that we do not deny care for those in need, particularly surgical patients. Thank you very much for your attention.
Thank you very much, Raul. We thought that after your last presentation a few weeks ago, that would be the last, but unfortunately you are talking again today because the situation is not controlled. So I'd like to invite now Dr. Omaida Velazquez, the Chair of the Department of Surgery at University of Miami. Dr. Velazquez has been leading our response here at the University of Miami Hospital, Jackson Memorial Hospital, all the University of Miami health system. And she also has some information to share about what's happening in Florida, Miami, and how we are dealing with this new research here. Dr. Velazquez, can you hear us?
Thank you, Antonio. Yes, I can hear you. I'm going to see if I may share my screen here. Good afternoon, everyone. Thank you, Dr. Martos, for the opportunity to participate in this webinar and share some of our experiences here in Miami-Dade County, Jackson Memorial Hospital, and at the University of Miami Health System. You know, just to start, globally speaking, this is really a situation that is vexing all of us across the world, and unfortunately the United States has positioned itself solidly here at the top of the list in terms of both the total confirmed positive cases and the total number of deaths, which now approach 130,000 deaths in the United States. Florida is definitely a hot zone. It is interesting that now when we travel to New York, we need to self-quarantine for 14 days. The tables have definitely reversed in terms of the acuity of the crisis here in Florida. And we're now exceeding 150,000 confirmed cases and more than 14,500 hospitalizations. And you see there the number of deaths exceeding 3,500. The demographics have changed a little bit. And you can see here that the number of cases have exponentially growing here in Florida. But you see a shift in the age groups a little bit to the left. So younger age groups, and this may be related to the fact that the younger population decided to break with the shelter at home concepts and the safety measures of social distancing and mask using much more aggressively than the older groups, which are, for the most part, from what I can gather anecdotally from speaking to patients and families and friends, the older age groups are still being very guarded and trying to be cautious and observe all of the safety precautions that have been outlined. Miami-Dade, where we are, is right here. In terms of incidence, is the 9th county in the United States in terms of the number of positive cases. So not only is Florida a hotspot, but the location of our main private hospital system and our main public county hospital system within Miami-Dade, we are inside a significant hot zone with increasing cases and increasing hospitalizations, as you can see there. These are the daily cases, or the tracking cases here in Miami-Dade, and you see that it's almost an exponential rise. Again, a younger population that we're seeing with a mean age in Miami-Dade being about 45. So what happened when we were observing all of the measures of transmission containment? We definitely curved the curve, if you will. We saw a flattening, as you can see there. These are the bottom show the dates. The y-axis shows the number of positive cases that we had in-house. This is data for the public county hospital system, and you can see that we saw a flattening of the cases, and we reopened, it reemerged from the shutdown on May 4th. And then we, a few days later, for about a couple of weeks, continue to see the results of the measures that had been in place and continue to see the downward trend in the cases. But just like Dr. Coimbra was telling us before, about 2 weeks later, then we see a significant exponential rise in what appears to be either a second wave or a resurgence of the first wave. And that is translating to many more inpatients that are positive with COVID, and many more patients that are ventilated. Again, we had seen a peak and a nice steady decline in the ventilated patients, but then about 2 weeks after the reopening on May 4th, we're seeing a steady climb up. This is also data from Jackson Memorial Health System, our county public hospital. In the private hospital, which is a slightly different demographics, interestingly enough, a very similar curve. We had plateaued and curved that incidence of cases very nicely there, as you can see. There was a good flattening and plateau. We were beginning to see significant decreases. We even closed the COVID unit. We have a vertically isolated COVID positive unit on the penthouse of the building for the hospital, the private hospital, and we had closed that down. But sure enough, about a couple of weeks after the reopening, and with all of the various events that were happening, holidays and protests from social unrest and whatnot, we saw a significant increase, had to reopen the COVID units. And you can see there the COVID positive inpatient census is still climbing significantly. Same pattern in the private hospital, UHealth system. You see in the ventilated patients, for a while there, we had only one patient ventilated. That was COVID, that was lingering. For a little while, we had none. As you see there, the flat curve at 0, and then a very steep resurgence in the need for ventilated cases for positive COVID patients. The ratio, however, of patients that are ventilated to the patients that are in-house is slightly decreased. So in the first wave, we were seeing anywhere between 20 and 30% of the in-house patients ending up in a ventilator. In this resurgence, we're seeing about 10, 15% of the total in-house patients needing ventilation. This is data back from the county hospital in terms of the trends of the COVID positive patients in terms of by level ICU care versus med-surg floor care, a steady climb on both of those levels of care. So in the county hospital, we're still seeing fairly significant disease. In the private hospital, we're seeing a slightly milder presentation of the disease. We're not quite sure what that means. Might be just a coincidence and timing. In terms of the recovery, we have been entering now phase 2B into phase 3, and we have not discussed a slowing down of the recovery phase. This is the graph representation of all of the outpatient encounters, clinic visits, in person and virtual. So in person, you see the bars in blue, the telehealth are in light yellow, and the red line indicates and the red line here indicates the comparison of what was prior to the pandemic. What was our average volume prior to the pandemic? And you see that when we had the elective shutdown to mitigate the transmission, we had a significant decline, and you see there the decline. And then after May 4, our rapid recovery was mostly telehealth as we build up the confidence of the patients and as we revise our protocols for social distancing across the infrastructure of the health system. But then patients really want to see us, in person. So you see the climbing of the height of the blue bars. Those are outpatient in-person visits. So patients want to see us. So as more and more come into the campus, a slightly lesser percentage are done via telehealth. But nevertheless, between March and June, we completed over 100,000 televisits, which was a significant part of our recovery strategy to incorporate telemedicine. This is another way to look at the data. In green is the in-person visits to the health system, ambulatory care, and in blue is the telehealth component. In terms of the operative cases, we saw a rapid recovery after the reopening, which we believed was a combination of the pent-up demand of patients that were waiting for their cancer and cardiovascular and other needs, and then also a increasing steady demand for new patients. And so by June 10, we were at 71% recovery in terms of the volume of cases in the private hospital. By June 17, we're at 87% of recovery, and those are across the various surgical specialties. And then by June 22nd, we were 92% recovery. And what we have seen in the last few days since June 22nd is a plateau of that recovery because of the resurgence. We are still taking care of all patients, both COVID and non-COVID. And we have launched a patient confidence campaign indicating that our protocols are ready to take care of all patients and that is safe. But nevertheless, we see a plateau in the low 90s. And there's some limitations to what we can achieve in terms of the recovery with this resurgence. This is the data on the recovery for the county hospital. So on the y-axis, you see the volume of procedures done. And on the x-axis is the days of the week, Monday through Friday. And it's a comparison of May and June for 2019 versus 2020. And you can see that there was a significant decrease, but then we recovered quite nicely when we reopened. But we are still hovering at approximately 80 to 90% recovery in terms of comparison with the pre-pandemic to now in terms of the number of procedures that are being done at the county hospital. And at this point, because of the resurgence, we are seriously considering a reversal of the recovery phase and a transition out of doing complex inpatient care procedures and focusing more on the procedures that can limit the ICU length of stay. We've been keeping an eye on all of the projections in terms of how many ICU beds and how many ventilators may be needed, depending on how bad this resurgence turns out to be, how high is that peak of the second wave. And the cone of uncertainty is significant, but we feel that we are prepared in terms of those resources. So that is less of a worry right now than it was with the initial wave. However, there's many new issues that are emerging here with this second wave or resurgence of the first wave. At the beginning, it was all about PPE and availability of ICU ventilators. But now there's many new issues, and I tried to summarize them here. We are seeing an increasing percentage of personnel that are calling in sick, and most of this is transmission in the community. And they're not always very, very sick, but they're testing positive and they have to be quarantined and therefore decommissioned from the active workforce. We are seeing a number of seroconversions among the frontline providers. We didn't see that as much in the first wave. And not only that, but we're seeing some in-house cluster transmissions, and we're actively investigating with contact tracing and trying to figure out what's going on in that arena. We are also seeing that because of our pre-testing protocol, we have a universal pre-testing for all procedures, elective and inpatient, and as well as outpatient. And then we also have a universal pre-testing for all admissions, including admissions from the emergency room. And because of our pre-testing protocols, what we're seeing is that there's a number of elective cases that are being canceled, which we didn't see before. And also there's a number of patients that are in the hospital for another reason, non-respiratory admissions, whether it's appendicitis or small bowel obstruction, or a myriad of other reasons which get tested and they're now COVID-19 positive. So they have two issues. We don't know to what extent the issues may or may not be related, but that is actually contributing to the numbers in-house. We are seeing some increasing concerns about the patchiness of the pharmaceutical supply chain. The latest one in this is remdesivir. We found out yesterday and today that there is an allocation hold for remdesivir to the state of Florida. So we may have a little gap. We have enough in-house to continue to treat patients, but we may have a little gap in the supply chain there. There's ongoing issues of confidence with the patients. They see the numbers, they see what's happening. And although our protocols are pretty watertight in terms of safety, many patients wonder whether they need to be consenting to any kind of elective care at this point, and they're choosing to postpone. There's also a lot of limitations to the confidence for patients to consent to any kind of big elective operation without having a family member holding their hand and staying with them through the process. So we're seeing that the no visitor policy, which is an absolute necessity for safety in our hospitals and our buildings, but that is actually decreasing the confidence of patients for coming forward for operations. We're also seeing what we believe is an incidence in the an increase in the incidence of the D614G mutation, which is been associated with increased infectivity. So a lot of our positive patients are coming to be positive for this mutation. And this, we believe, may perhaps be linked to some of the increased cluster transmissions that we're seeing and the in-house transmission and the ease with which some of our frontline providers are seroconverting, but we have no proof of that yet. We really need to continue to look at this very closely. Lastly, like I mentioned, we are beginning a discussion, a very serious discussion about how do we continue to take care of patients with COVID and patients without COVID, and still balance all of the complex necessities and issues at hand. And this may require shifting to more outpatient care, maybe postponing the complex quaternary, long length of stay, long ICU stay type of cases. In conclusion, I think that what we're seeing is that we're being asked to manage this evolving crisis while balancing a number of very complex but all very important priorities. You know, we need to meet the needs of the patients based on acuity level of presentation, but we need to be thinking of both COVID-19 and non-COVID-19 patients. And this goes back to the concept that Dr. Coimbra was mentioning, coexisting with this disease somehow. We need to keep an eye on the potential limitation of resources. We started out very, very worried about PPE, ICU beds and ventilators, but now we are more worried about issues with personnel calling out sick, not having enough testing supplies, and having some gaps in our pharmaceutical supply chain. And of course, the financial implications of all of this is ever present in everyone's minds relative to the inability to continue business operations as usual, and therefore seeing significant hits on the revenue side. I'd like to finish by acknowledging that all of this great updated to the last few days data was provided by the group of great doctors and individuals you see here, and I'll leave it at that, and I'm open for to the discussion that follows and hearing the other presentations. Thank you very much, Dr. Matos.
Thank you very much, Dr. Velazquez. So your data is very similar from Dr. Coimbra. You had a plan in the beginning, you follow a plan, and now I've seen this research to happen. So the third presenter was going to be Dr. Perdigao Cotta from Paris. He called me 1.5 hours ago saying he will start a case, but he asked me, he requested me to share his presentation. And I'm gonna quickly show a little bit of his slides because this is gonna have some substrate for our discussion. And I had a long conversation to him about this, and he said that, I said, Fabiano, what's happening in Paris? And then we're gonna discuss his findings and also with the other colleagues from Europe. So he's from the University of Paris, Hôpital, Pitié, Sorbonne University. And he said France is currently the number 5th in the globe in number of cases and mortality. And he said his first case happening in January 24. The first death in France was February 14. They started a lockdown on March 17. And they started the reopening May 11. So they had a long time of lockdown over there. And after the reopening, they have a multiple criteria, and they said that the last area to come to normality in France was the northeast part of France. Now everything, the whole France is pretty much is green, with not a lot of cases. And again, it's saying that the number of new admissions, the number of new cases, the new hospitalization, the ICU care is still very low. It was never as low as yesterday, he said. And then the reopening in France happened, it's still happening, and this is the data he shows. So he's saying that after the lockdown happened on March 17, was still going up. The reopening happened on May 11. And you can see that the numbers are way down and continue down up to yesterday. And he's saying the same thing happened with the visits. And again, after the reopening, the numbers are still down or still going down. And the number of deaths also said the number of deaths in Paris was huge in April. They continued to go down. They reopened, and even after reopening, the numbers are still down and very, very pretty much at the lowest number they ever had. As you can see, also there's another curve saying the patient on ventilators and ICU, again, the numbers are really, really, really down. And the same thing on new admissions. So I asked him, so what's happened? So why do you think that you have been successful with the reopening that not having a new research? And they said, well, let's discuss the slide. I told these are the requirements in France, the current requirements in France. He said that no more than 10 people can be together in any public space, okay? So the schools, the high-level schools, and universities are having distance learning. The primary schools and secondary schools, they are back, and the kids are back to school. So main activities are and places, they have mandatory rules, like shops and markets are all open with health measures in place. You should wear a mask. Bars and restaurants are open with the same thing. Limited capacity, no big groups, and everybody wearing masks. Cinemas, shows, casinos, they are open, but again, no more than 5,000 people per venue in a place. Nightclubs are still closed. Stadiums and racing tracks gonna reopen in July 11. So they did not reopen the soccer, the football, but they're gonna reopen in July 11. But they're gonna reopen to public, but with a limit of 5,000 people per venue. And right now, for the contact sports not allowed, but gonna reopen 11. And again, the plan that they have, anything changed, they're gonna go back and reduce the number of people and be more restrictive. Regarding employment, they say in France, everybody can work from home. I still work from home. If you work from home not possible, they're asking the place to try to accommodate, social distance, and try to reduce the number of people. But most importantly, it's mandatory to wear a mask all times on public transportation, for example. Travel to France, travel in Europe has been reopening, but it's not reopening from the United States. If you're from the United States or from South America, you still cannot travel to France. At the hospital, again, they saw a decrease in the number of positive COVID patients. So they start to reopen the other sectors. Elective surgery almost 100% again today. And the same thing Dr. Coimbra said, the same thing Dr. Velazquez said, at some point they need to coexist patients with COVID and non-COVID in the same hospitals. So, and they need to be very careful how to interact with this patient and try to run two separate hospitals at some point. They have multiple protocols at the hospitals. They have questionnaires to the people that go there. But his conclusion is that he said that the lockdown was necessary and helped a lot. It's not still over in France. It still has a lot of restrictions. Social distance still being respected. And if you cannot have a social distance, the mask is mandatory. And then he made a comment, a final comment, said, you know, Antonio, he said he believes that different from the United States or Brazil, where the federal government has a power, but the states has a lot of power. Said in France, the federal government mandates all the response. Said the federal government scared everybody, so everybody was scared, and up to now, people are respecting the rules, and they said if you go to the streets, everybody wearing masks, everybody keeping social distance, everybody washing their hands. So I'm gonna finish here. So I'm gonna go, let's go now to the discussion, because we have some panelists from Europe, we have some panelists from North America and from South America. I would like to start asking Dr. Carlos Yanes. Dr. Yanes, so what happened in Spain? Quickly, a brief summary. What happened in Spain, and what do you see now happening in Spain at this moment after reopening?
Great. Thank you, Antonio, for the opportunity. I have only a couple of slides that I would like to share with the audience, so it can give you an idea of what is our situation. Okay. So the situation right now in Spain, we open up by phases. It was rather curious. I like what Raul said, that you need good data to make decisions. So we made decisions based on really was like 5 phases. around 85% of Spain right now is what we call normal situation or new normality. So new normality means that we're open, we don't have restrictions inside about 80% of the country until this week. Last week it was all open. Venues, public venues, restaurants, and cinemas and all that, it's about 50% of capacity. Trying to, of course, limit more the capacity where it's inside. So we're trying to eat outside when we have to do that. And sports activities, we have, we did retake football. That's, you know, that's our national sport, like in Brazil and the rest of Europe. But we have no fans in the stadiums. So that's, I think that's important. The thing is that the information that we see here is what's really official by the government. We're talking about around 28,000 deaths, a little bit over that, and 250,000 confirmed infected cases. So if we see that this is a situational report from yesterday regarding the situation in Europe, we compare, we see here in the first column the total number of infected or confirmed cases. You can see that we are around 250,000, and we have 200,000, 200 cases reported daily, with 3 deaths yesterday. But the thing is that we've had like some issues with the data. So current data that is non-official, but it's what we manage, is that it's probably around more like 40,000 or above 40,000 deaths. So what has happened in Spain is that, as you remember when all this started, in Madrid, we used to be the hotspot and vast country, but especially Madrid and Barcelona. But we had real strict lockdown. We had around 6 weeks of real strict lockdown. You couldn't go out, only for work. If you were a doctor or essential worker, but the rest of everybody was home. So after they lifted these restrictions and we went through the paths of the phases, the people in Madrid and in Barcelona started to, move to their second residency, and also they tried to, get away from the big cities, looking for more rural regions. So right now, the situation is this one. We have a high-risk zone here in Zaragoza, where I am, up at north, close to France. And that's because of a lot of meat processing plants, a lot of agricultural activity up in the north with fruit collection. And the rest of the map, it's like this yellow intermediate risk that we're having about 20 or 25 focus of activity, not as intense. Surgically wise, in the hospital, we're opened to around 80%. We're performing elective surgery. And what we're doing is that we do testing, like Raul said. We're also on the testing side. We test the patients, and we're also self-quarantine the patients, elective cases 1 week prior to surgery. And we do testing 48 hours prior to that. All the cases go through a committee to try to select the most stringent cases, because after 6 weeks, we had a lot of updating to do in a lot of cases. And the situations that we're having right now, as you know, is Spain is very important for tourism, the economy. So I think it's been hard to make that decision to open up, but we're trying to reinforce controls in the airports and trying to get back to normal. So I would just like to I think that I agree with Raul that I think this is not yet for us a second wave. I think it's like the end of maybe the first. I think we had some doubts if there was going to be a second wave. I don't think we have it now. I think we're going to have it, not only here in Spain, but I think worldwide. The question is when and how are we going to prepare ourselves for it. So this is the northern region of Spain, and this is where the people are going. So ironically, it used to be in Madrid, and now this is the hot spot. It's the rural regions, but well, you see the mountains, so people are trying to get away from that horrible situation. And saying that, I want to express my gratitude to all the panelists, and especially to you, Antonio, for the invitation. Thank you.
Thank you, Carlos, for the information. So we all can see through this presentation that we all did the same, right? We had a problem at the peak in March, April, we locked down, then we reopen, we have rules, regulation for reopening, but Europe is doing better than the United States. And I just make a comment before going to Michael Butano. So I was on call 2 nights ago, and then we are receiving trauma patients with post-COVID. So for elective surgery, you can screen the patient, you can kind of select the patient that's going to go to surgery, but trauma has been a big issue. And one of my patients was a young patient, was his birthday, and he was celebrating, drinking with his friends, and then have an accident, he was drunk, and then he came, he was positive. So this is going to be my question for the panelists. Are we going down here in the United States because the young population thinks that they are immune to this, or they, and like Dr. Velazquez said, the group age of the new patients are younger? Is this a cultural problem that we're having, or they're not the young population not hearing the message? So that's my comments. So I'd like Michael Butanos now to lead the moderation of the discussion panelists. Please, Michael.
Hey, thank you, Antonio. Really great, great presentations that really make us think about it. I had a couple of questions actually to all the panelists, but you know, and the reflection with regard to what is sustained restriction versus non-sustainable restrictions. And so this, if you look at the France presentation, for example, and what they have put down, which is a little bit different data from the other two presentation. So Dr. Coimbra, for example, in your presentation, you said, I have a feeling that we are doing worse. And so the question I have for you, but are you more prepared than before for this worse to come? And if you are, does the preparation have to be different? Especially if you look at what Dr. Velazquez presented, how it's a different kind of a crisis and preparation. I would love your comment with regard to that.
Thanks, Michael. I think we are better prepared. You know, the second time is always a little more comfortable and perhaps easier than the first time. Obviously, between the two, we had chance to stockpile PPE. We had the county has a good reserve on ventilators to distribute to hospitals. So I think from a response of a healthcare system point of view, we are better prepared. What happens is that as a society, I don't think we have responded the way we should. And that's the big difference that you see. And I hope we're going to discuss that, the whys. Why is it that it doesn't work here and it works so well in France, Germany, and has worked in Italy and in other places? But in terms of hospital preparation, I have no doubt that we are better prepared. But always it's a matter of how many come in and how many resources you have available. If the second wave is as big as the first or bigger, then we are going to be in trouble because the resources are not endless.
So, Dr. Christoph, Justin, what's your input from Germany with regard to how is it compared to it?
Jetzt fragen Sie mich. Jetzt fragen Sie.
Dr. Justin, are you there?
Do you hear me?
Yes, we hear you.
Yes.
We just want to get your input with regard to Germany. And
yeah. As you have seen by the statistics, that in Germany we have been in a quite safe way. Because we have had enough intensive care units. So we have had more than 3 times of ICU beds compared to Italy. So we have had never a problem with ICU cares. And on the other side, we had a very strict regulation and central regulation so that we had clusters where university hospital had the lead, and they organized all the transfers of the COVID positive patients. That was the one thing, so that we have had enough beds and people to treat them. Even that we had the chance to treat Italian peoples and French peoples in our hospitals. So maybe we have been lucky on the one side, but we have also patients coming from Austria had this infection. And on the other side, I believe we had been quite well prepared due to the huge amount of intensive care patients, intensive care beds. So that was one advantage we have had in Germany. So this is the explanation. And we started very early with testing, and I heard it. So we started in our hospital already in April, the 1st of April, to test all patients coming in our hospital. And so we have had the chance to pick up the patient with COVID positive patients before coming in the hospital. But perhaps we have been lucky.
So that's kind of answers the part of the question that the Coimbra kind of put back by saying, let's get into the why of why this is. And it sounds like part of what you said is earlier testing that happened in Germany. And, and then with regard to your critical care management, I would love to have Dr. Scalea with regard to why, where we are and versus where we're heading, and how come other places are not going the exact same way.
Well, you know, Mike, it's a complicated issue, and I think that a bunch of the why we are seeing what we are seeing in the United States has to do with the way Americans approach this. I can tell you we're seeing the same trend as everybody else is. We're getting more and more COVID positive patients. Our injured patients are COVID positive, and it sounds a little crazy, but the people around here, particularly the people that have been economically so hurt by this, say we got to reopen. We can't exist if we go back to work, and if some people die, that's the price of us reopening. And that when you hear the people outside the U.S., there's a very different approach to life, if you will, and it just is. I'm not making a statement that I think it's a good idea, or I don't think it's a good idea, but I understand the pressures on them. We're seeing the same thing in the hospital. As we're starting to surge again, the elective surgeons are saying we can't go back and not do elective surgery. It's not possible. And there's a real clash developing. I can tell you that the economic impact to the practice plan at the University of Maryland for last fiscal year, $35 million. It's a lot. That's just a practice plan. That's not the hospital. And so these are real forces, and they'll get played out the way they get played out, but it's about people's willingness to hunker down a second time.
Okay. Thanks, Dr. Scalea. So I'm going to actually put this back to Carlos, because you mentioned in your quick presentation that you're very sure that Spain is going to go toward the second phase with regard to this. And is there a difference between the responses? We're looking at the why between Spain versus France, if we're just talking about non-US, just European countries.
Yeah, well, I would say that there are, of course, it's very difficult to analyze this situation because each country, even each continent is going to be different. And we're going through the pandemic in different phases. But one of the things, or one of the issues, at least in Spain, is that we're very, and I think we're internationally known for this, we're very sociable. So people tend to, get together and have some drinks, and especially in summertime. So that's one of the concerns that we have. Also a lot of tourism. So I don't know, probably this year we won't have as much as we would want, or the economy would want. I think maybe it's early, but one of the things that we're having is that not everybody is wearing masks like they should. And this is a pattern that seems to be universal, especially young people. So at first we used to be like a little bit more careful. Now I see that we're being a little bit careless. Inside the hospital, I think we're like expecting the worst, wishing the best, because that's probably what's going to come. I hope not, but we have to be prepared.
Okay. Thank you. Antonio?
Dr. Velazquez, I think it's very similar situation that from California, from Baltimore, and in Miami. So you said, point some data that now the proportion of patients intubated is lower than before. So we have more the young population getting sick, and they're kind of healthier. But what are you expecting the next 2 weeks? And what kind of message? How can you fix this with the young population? Is a message to how can they understand that they can put everybody in risk, the system, the finances, and the hospitals, and everything if they don't follow the rules? So what's your point of view about that, please?
Yeah, it's a silver lining in all of this to see that while hospitalizations are up, the ventilated proportion is not as high as before, and the death rate continue to go down. So all of that is good. Having said that, we don't know the biology of this new disease too well yet. We don't know what this new mutations, the D614G mutation in the spike protein, how it's going to increase the transmissibility. How will it behave biologically with time? Is it going to be a more subacute and chronic presentation that will come back to haunt us 2 weeks down the line, or a month down the line, or a year down the line? So we don't know a lot about this disease, and it's hard to frame the message for the younger populations that feel that it's not as much their problem as the problem of the elderly and the frail. As you know, Antonio, here in Miami-Dade, they have tried to do some things, like, for example, they allow the restaurants and the bars to be open, but they're not allowed to sell liquor. So I suppose that idea behind that could be that these younger populations, they start out a little disinhibited, and when they drink, they may get even more disinhibited. So maybe they want to have people thinking of common sense when they're out there trying to have a normal social life. But it's a tough question. What do we do? How do we message to the population at large, particularly the younger groups, that this is still a huge public health problem, and that we have to take it seriously, and that we need to institute to the best of our ability whatever safety measures we can do, which is at this point mask, social distancing, and hand hygiene. So I don't have all the answers, but I think that it's going to need to be a very formalized campaign that floods the media, television, radio, social media, all of the channels, to change the culture from one of, oh, we're done, this is history, and don't worry about it, to we're still in the middle of a crisis and everybody has to chip in.
Thank you, Dr. Velazquez. Raul, we still need to do transplants. We still need to do oncological surgery. And last week, Dr. Lemoy said he also needs to continue doing surgery. So Dr. Scalia said there's a huge problem with elective surgery. So Dr. Raul Coimbra, so how can you provide this message? So what can be done to the population? Like 4th of July, Miami-Dade, they want to close all the beaches for 4th of July. No celebration on the beach. But there's some parks in the north of the state that should come for the fireworks here in one of our parks, you know. So So how can we have a better message to the people? So what's your view about that?
Well, you know, we talk about the problem in the United States. In my opinion, for several weeks, I've been saying the same thing. It seems that we have a messaging problem. I personally think that the country failed completely in terms of leadership and messaging to the public. I totally agree with Tom Scalia that, you know, America is not Germany, is not France, is not Italy, it's not Spain. The public behaves differently. The laws are different. The states have a lot of individual power and decision making. The public is not accustomed to restrictions, particularly social restrictions. And the response is very different. And unfortunately, we are currently divided in half. And there are still a significant number of people that don't believe that this is real and don't believe that the measures that have been implemented or recommended are important. So we either have somebody that steps up and comes out and exerts positive leadership and informs the public and then enforces those measures, whether you do this at a county level, at a city level, a state level, or a national level, or this is not going to work. That's the reality. You know, we know the measures, masks and etc., but the message hasn't been clear. And we have not enforced those measures, whereas in other countries, those measures have been enforced and people respond more positively to this social limitations that are imposed upon them. So I think that we are going to get to a point where, like Dr. Fauci said, 20-25% of the population is infected. The mortality rate's going to go up dramatically through the fall. And hopefully some immunity will be developed, because I don't think in our country people will abide by the measures that are obviously important to limit what's going on now.
Thank you, Raul. I have here two panelists from Brazil. One is Dr. João Grangeiro. Dr. Grangeiro is a legend physician there. He was a volleyball player. He was in Olympic Games in Moscow as a player. Then he was in 8 Olympic Games as physician. And he's the director, the CMO of the biggest federal hospital that does orthopedic surgery. And he was sick. And a couple of weeks ago, I left a message to him. He was in critical care unit, sick. Dr. Grangeiro, I don't know if you can connect to us. So how, being a patient, what can you say about this disease, and what's the message you can give to the young population? Or I know Brazil, Rio de Janeiro reopened while they are still in the peak. So what can you say about this disease, Dr. Grangeiro? And I'm very glad to see your face and recovery join us today. Thank you, João.
Yes, Antonio, I'd like to thank you very much to be participating in this show web seminar. I'd like to congratulate all the speakers and panelists as well. So I will try to make in very few words my experience as a patient, and afterwards I will bring some key points in my opinion to face this terrific disease. So I'm 63 years old, man. I'm a healthy guy, and I spent 36 days in hospital here in Rio de Janeiro, in Samaritano Hospital. I'd like to congratulate the Ricardo Lima, who is the head of the ICU where I was admitted, and my close friend Mauricio Weissman as well. I was not under oral tracheal ventilation in spite of very low oxygen saturation. My clinical conditions deteriorated very fast as CT lungs imaging. I got about 50% of all the lungs consumed by the disease. I'm quite sure that adjustment of high doses of corticoid as well sedation with precedents were a very important point in my recovery, and in that way I tolerated the BPAP with the mask and oxygen high flow and pressure. I lost about 22 pounds in 3 weeks, and following by impressive weakness muscles. And respiratory exercise are very important and must be initiated as soon as possible. That's my personal opinion. And high protein diet should be put in place. Now I am in rehabilitation period, doing aerobic and the power training exercise, and with the monitorization, because in my initial ergometric test showed some ventricular extrasystoles. So this is a I think Antonio and the friends, it's a very hard disease for sure, and the course of this disease is still unpredictable. Probably no intubation could be a first choice for critical patients. Corticoid should be launched soon. It just works for me. Protocol treatment should be individualized. And we think now, we are, unfortunately, we are not in the end of this terrific pandemic. And we think we need to start to think off-label medications like ivermectin could be used in patients with very low symptoms at home stage in the way to avoid hospitalization. So I think that we are not even close to the end of this pandemic, and that will be very important. Some clinical robust studies which allow us to use some off-label medications on the beginning of those symptoms. So instead of to avoid impacting a lot of our hospitals and our surgeries and other clinical procedures at hospitals. So this is just my little contribution for this web seminar. Thank you very much for the opportunity.
Thank you, Dr. Grangeiro. It's sad to see healthcare professionals getting sick, and this is happening everywhere. A lot of healthcare professionals got sick in Italy. We lost some people that you know here in the United States. So, Dr. Lima, so any other recommendation, any other comments about how can you prevent this resurge of cases?
Good evening for all. Good afternoon. Thanks for the opportunity, Antonio. I'm very glad to be here, mainly to see my former patient, Grangeiro, now sit with us to discuss about it. And it was a pleasure for us to attend him. But unfortunately, I still do not believe there is no means to prevent this disease unless to make some lockdown, to make some social measures, and to wash hands and to use masks for that. And in Rio, we are reopening. I suppose that I agree with Dr. Coimbra when say there is sometimes 20% of people will be contaminated. There is some mathematical theories. It's difficult to put exact science in inexact science like medicine, but they used to say around 8% of people will not be contaminated or are resistant, something like that. But 20% are contaminated, or 20% around that people are susceptible to the disease. But I don't know what happened. I don't know if probably or certainly the virus is not the same we began this pandemic. There are changes, they mutate. I hope for a weaker virus like that. But now in Rio, reopen. We are finishing. I used to have 70 beds for COVID. Now we are with 5 patients in all hospital of COVID. We are keeping a little unit to support these patients. We opened the hospital, and Rio de Janeiro is in phase 3 of opening, but we don't know what's happened. People, like my colleague says, and Coimbra told us, is not used to stay apart. They want to be joined. We do not close the beaches. The beaches in the weekend are full. Soccer is coming back, and we don't know what's going to happen. The idea is to share the hospital. We have a little space for future COVID, but the patients are the 2 kinds of patients we are receiving. Some COVID patients, but in a weaker picture, and we are receiving a lot of pneumonias. That patients, I suppose, they were sick in house and home, afraid to come to the hospital, and they are now coming, and we are using for this kind of patient the rapid test, and we decide if they go still for the unit. And the last 20 patients we suppose were COVID. Only 2 were really COVID in the last 10 days. But I agree with my colleagues that the next days we will see. The data we see in Rio, I'm sure there is a late data. We are showing death and cases from a couple of weeks ago. And in weeks, we are going to see what's going to happen after the overture. And we hope now what the colleague says, we will be more prepared to receive these patients. Thanks for the opportunity.
Thank you, Ricardo. I go back to Michael, but just making a comment before. I have been part in a study here at University of Miami with a therapeutic treatment, and I was able to consent 4 patients in the last few days for this treatment. And I saw young people on the 30s and the 40s really sick. They can barely talk, can barely say their names. And again, maybe the message for the young people that this can be dramatic for them also. Dr. Butanos.
Thank you, Antonio. I'm just going to reflect on the very similar thing we're seeing here in Virginia, especially also in our hospital. And like Dr. Coimbra already talked about with regard, and Dr. Scalea, both the trauma is not stopping and emergency general surgery is not stopping, except now they're coming in with COVID at the same time. So I'm really interested in this concept of the hospital within a hospital. I think this is something we just have to figure this out. And I think this probably would be a good focus for us moving forward. How are people doing it? If there's going to be an inevitable way of doing it, how do we survive as a hospital within a hospital? Because there is, like, I think Dr. Scalea mentioned this, there is a huge opposing force to this. We've been asked to how to reopen the hospital. How do you get patient in? You know, and how do you create confidence that the hospital is an okay place for you to come, which is kind of a different aspect. If that's true, then you have to be able to create that hospital within hospital section. So I actually wanted to bring it back to Dr. Coimbra and for him to have the last comment, if possible, Antonio, on how do you see this hospital within a hospital concept?
Yeah, so you know, if the natural history of this infection is similar to other coronavirus infections and other viral diseases, we should see less acuity, although the number of cases remain high. And Dr. Velazquez pointed this out very well in her presentation, that the number of ICU admissions is going up, but not going up proportionally to the number of cases like we saw in the first surge, and the number of deaths have not followed. So we have to create mechanisms by which we define an area and a number of beds and ICU beds and floor beds and ventilators and all the resources to run almost independently of the rest of the hospital, and coexist with them. You know, maybe separate elevators, separate pathways, separate entrances to the operating room, even if it requires structural changes in the hospitals. Or you build capacity next to the hospital. Like I said, some hospitals are already working with the idea of building ventilated tents for COVID patients, not letting those patients come into the hospital if they are not really ill and require ICU. So they are freeing up additional beds inside the building for patients that are COVID negative to assure the public that the hospital is a safe place. So this is not as simple as it sounds. It's complicated, but I think that the institutions that develop those strategies, particularly large healthcare organizations that have multiple facilities, can do this more effectively with a cost sharing strategy without taking too much of a financial hit, because this is going to be part of the daily life of every hospital in America.
Dr. Velazquez, this is going to be with us for a couple months or years. So how can you increase patient confidence? How can you, a system like our system have more than 10,000 surgeries per year? How can you keep providing the service that the population needs? So what's your view about that? What's your message to the other centers in America or in the world? So how to coexist with this disease and providing surgical service to the patients that need that?
Thank you, Dr. Martos. I really like the idea of the hospital within a hospital concept. We have been calling it running two hospitals in one, and that's what we've been doing at the private hospital. The hospital leadership from very, very early on decided they were going to have a vertically isolated floor with separate elevators, separate transport teams, separate entrances, separate everything, with access to negative pressure operating rooms, with a procedure room outside of the COVID unit. And essentially, we're running two hospitals in one, and it's worked well. For as long as we can allocate personnel to both hospitals without shortages in that arena, we will be fine. And the confidence campaign has surrounded this idea that there's no commingling of the COVID patient care and the rest of the care in the hospital. And that we have extensive pre-testing for everything that we do, whether it's procedures, operating room, staff, and extensive barrier protocols and PPE and so on and so forth. So I think that is really a concept that we need to continue to explore in terms of how to expand it. I like the idea that Raul mentioned, which is to think about even a tent hospital, which would expand the capacity for beds for the COVID patients that don't need ICU care. One of the ways that we managed to do it in terms of the two hospitals running in parallel is we closed the MICU. So the MICU team dedicated themselves fully to the care of the COVID unit, and the overflow of non-COVID MICU was distributed across all of the ICUs, mostly the surgical ICUs. And so the surgical ICUs were carrying a combination of medical and surgical patients, and that's worked very well. We've also had a grid of escalation in terms of the number of MICU teams that are mobilized depending on the number of in-house COVID patients. But we'll see. I think we don't have the answer. We're going to have to continue to explore this concept of two hospitals in one, or a hospital within a hospital. And the confidence piece, the visitation policy is a big part of it. And it might be that once we have enough testing capacity, we would have testing protocols for the visitors that are similar to those that we use for the patients. And that could get us that extra bit of confidence for patients to sign up for elective major surgery.
Thank you, Dr. Velazquez. Dr. Butanos?
I just want to, Antonio, I think this was a phenomenal presentation again. And we will continue to do this as long as it's needed with obviously with your leadership and capacity that you brought and the excellent panelists. And maybe we'll have perspective from Germany also next week. Maybe Dr. Johnson give more of a presentation as well as we continue this kind of like a seesaw. The experiences are different in different places. But and I just want to thank all the leadership with regard and all the panelists for this for the continual support and this message moving us forward. And obviously, always thanking you, Antonio, for making this possible.
Thank you, Michael. I would like to finish this presentation with a happy slide. So, first of all, I'd like to you're all friends, you're learning each other. So, if you when some of us goes down, so Carlos, Michael, Raul, Ricardo, Omaida, Justin, João, thank you for being here. We are friends. We are in the same group. We are fighting for this. And I'd like to finish this in the name of the Panamerican Trauma Society, the American Association of Surgical Trauma, the National Relations Committee, the World Coalition for Trauma Care, University of Miami, and VCU, Virginia Commonwealth University. I would like to finish this with an homage and honoring Dr. João Grangeiro. Valeria, put the slide, please. He is one of us. He was down. He was sick. And we all prayed for him a few weeks ago. And now, Grangeiro, we are very happy that you are here with us. You are healthy. Looking forward to meet you in person in the near future. Okay, João? Thank you very much, everybody. You are finishing this conference today with this happy message. And Valeria, Gary, Glad, Stephanie, everybody that work in the back to make these meetings happen. Thank you very much. Hope to can see you all safe next week. Thank you.
Thank you so much, Antonio. It's a great pleasure.
Thank you, João.
Thank you. Take care.
Thank you for the opportunity.
Thank you, everyone. Take good care.
Thanks, Antonio. Good to see you all.
Thank you, Raul. Bye-bye.
Thank you a lot, Antonio. Thanks a lot.